Well, thank you very much, Segan. That was an outstanding talk. So I'm going to focus on future of prevention and treatment trials in Alzheimer's disease, specific to Down syndrome, but I don't want to undersell what Dr. Hartley just talked about, lifestyle differences. I think anybody who's been paying attention to the news, there's just a big story about diet implications having very profound effects too. So I think with regards to Alzheimer's disease, we have to approach this from all different angles, and they're all very important. A brief introduction of myself. First of all, it's great to see everyone here. It's just so wonderful to be in person, and most people, it's great to see faces and smiles and everything. And also everyone online, I can't see you, but thank you for joining us today. I am a professor here in the departments of medical physics and psychiatry. I also show up there in addition to our wonderful Weizmann Center and what it looks like when there is no snow out. The little splashed emblem of the Wisconsin Alzheimer's Disease Research Center, and I'm very active in that, and it integrates very closely with what we do here also at the Weizmann Center. So as Dr. Hartley described, we have this disease of plaques and tangles are the dominant features of Alzheimer's disease. And when Dr. Alzheimer back in the early 1900s did his first autopsy, this is what he saw. Kind of the visible feature were the plaques on the outsides of the cells, and I call it plaques, these are beta amyloid plaques, so I'll be probably after this slide switching to calling it amyloid. And then the other are the tau tangles or neurofibrillary tangles. And being the signature features. Now that's not all there is, of course, but by definition, him seeing and identifying these at these times, this has to be present for it to be called Alzheimer's type of dementia. There are other types of dementia, but they would not be Alzheimer's if we don't see the presence of the plaques and the tangles. And as Dr. Hartley mentioned, there is a reason we have elevated plaques in particular in Down syndrome, because they're genetically predisposed to it. So I'll dig down a little bit deeper with what goes on with the plaques and show this little cartoon figure that's provided by NIH, very nicely illustrating it. So you see on the figure, the APP is the amyloid precursor protein, and that is a protein that's tethered to the cell surface. We all have it. It serves a function in our brains. It helps with neuronal growth and function. And of course, it's recycled. So what happens is there's enzymes that can cleave it off, and it can be washed away. The problem is often it can be cleaved by a particular enzyme called beta secretase, along with gamma secretase, and it leaves behind these little peptide fragments up there labeled as beta amyloid peptide. And these little fragments are sticky. They aggregate together, and they can form in kind of patterned groupings. And as more of them form, they're called oligomers, and they continue to be sticky, and they can form these fibers. And the fibers then aggregate into these plaques, and the plaques are what coat the surface of the cells. And that's what Dr. Alzheimer first noticed in the brains of people that have died and had dementia towards the end. So really from that point in the early 1900s up until the 2000s, many decades of scientific research, there was no way to tell the presence of these amyloid plaques or these tau neurofibrillary tangles in the brain without waiting till someone had passed and doing an autopsy on their brain. However, just an incredible advance was in imaging and the ability to take someone, inject a radioactive tracer, a dye into them, and it's a specific molecule that will bind to these plaques, these amyloid plaques, and there's a different one that binds to the tangles. And we can take an image of someone and see the presence of them. And that's what that slide, or the images in the middle show. And just to provide a little bit of clarification to that, these are images, they're color rendered. And I once had somebody say, oh man, I hope I don't have a bunch of those red plaques in my my brain. So this isn't what it looks like. This is the creation of the image. It's just like when you see these beautiful images from the Webb telescope of stars out in distant galaxies and galaxy formation. Those are all color rendered. That is, color is added to them to illustrate the effect. And that's what I'm showing here. So I might show different colors in it. It doesn't mean that these colors exist in your brain, and that's what the plaques look like. So a bit of clarity in that. So there are other neuropathological features to Alzheimer's disease, but I'll stick with plaques because in the realm of new treatments ongoing, that's where most of it is focusing. And this serves as a foundation for the amyloid cascade hypothesis of Alzheimer's disease. That is, the whole pathway is kind of initiated with the accumulation of these plaques in the brain. It sets off neuroinflammation and then neurodegeneration, that is, cells die, and then we see cognitive decline at that point. It's one theory that has been reinforced throughout the years. So now let me talk to you and just introduce this study of the ABCDS that Dr. Hartley talked about, and we have been participating in. So this is a large scale study now. Internationally, most of our sites are in the United States here, as well as in the United Kingdom. The University of Cambridge participates too, and our goal is to bring in 550 adults with Down syndrome and do a biomarker study. Now, we refer to this as an observational study. That is, we're just looking at how things progress. We're not attempting any treatments. We're not looking to perturb the system at all. We just want to see, under normal conditions, how are changes going on in the brain. And specifically, biomarkers are measures that would be indicative of disease presence and progression. So we want to use these biomarkers, and I have talked about imaging-based biomarkers. We're also doing a lot of measures in biofluid that is looking at the presence of these proteins in blood as well as CSF. And then we have cognitive-based biomarkers too. So the goal of this study is to track biomarkers over time, ideally defining some opportunity window when treatments then would be most effective. Now, the University of Wisconsin started in this project way back in 2009, before it was ABCDS, but now it's spread throughout the United States. The University of Wisconsin, the Weizmann Center, is the top enroller for this study, which I humbly think, I'm not humbly. I'm very proud of the fact that our families, I think, are the most awesome and willing to participate and help out with the study and give their time so we can learn more about this. So it's very inspiring to be part of it here at the Weizmann Center. And here we have our very own Danielle modeling the umbrella. She looks very natural, could be that girl, Marlo Thomas, from years ago. She just looks wonderful in it. Good job, Danielle. So if I focus on just the neuroimaging biomarkers, I talked about the amyloid plaques, and that would be the column, the first column there. And each row in this figure represents a different participant that has been in our study. And as we go down, we see different degrees in the presence of this measured amyloid from the image, as well as tau. So that first column shows the level of amyloid, and you can see the top row, there isn't very much amyloid, as compared to as you go down and you see the brighter red, indicative of more of it accumulating. And again, these are all different people. And the middle two columns show the corresponding MRI. So the second column would be the MRI showing where we are in the brain with the amyloid image. And then the far right column shows that tau image. And this is the other protein that's misfolded, a pathological feature of Alzheimer's disease. And again, you can see that when we have low amyloid, there's usually low or no tau. And it's when we get a great deal of amyloid in the brain, that's when we start to see this tremendous amount of tau present. Now, what we've learned from studying sporadic Alzheimer's disease is that cognitive decline tends to track more with the presence of the tau. Amyloid comes on very early, and the brain seems to manage its presence for on the order of 10 to 15 years before ultimately tau will emerge, and that's when we can track with cognitive decline. So there's a lot of value in studying or knowing the trajectory of both of these. And here is some of the data we've acquired in our study over the years. So the horizontal axis shows the age of our participants, and the first dot would be the age at which they entered the study, and then that y-axis, or the vertical axis, shows the amount of amyloid that we've measured in their brains from our images. And the dotted line is a threshold we've determined of what we would call amyloid negative. That is how much is typically in anyone's brain when it's not in an elevated sense. And then above the line would be what we would classify as amyloid positive. That is beyond just the background signal. So you can see just a couple of observations. As Dr. Hartley was suggesting, there's a range of when not only people will be diagnosed with dementia, but when they'll start to accumulate this amyloid. And once they cross the threshold, we only see it increase. Where you see lines connecting multiple points, that is part of our longitudinal study that is following people over time. And we have some people that have been with us for over a decade. We've done 5 scans, and we can see the accumulation of amyloid in their brain. And another component that Dr. Hartley didn't present here was relating the presence of these. That is, how does the amount of amyloid correspond to what we're seeing in cognitive function? How does it with tau? And I'm not going to go into that, but we have been studying that too, characterizing, the timing when potentially we could expect to see someone start to experience cognitive decline related to Alzheimer's disease. Okay, so that's the background. Again, I've only presented the amyloid component of it. There are many other areas in Alzheimer's disease research that are being looked at. We're going to focus on this as I get into what I think is the heart of the talk, and that's looking at treatment trials subtitled The Inclusion of People with Down Syndrome. But let me give you a little bit of background first. So if we focus just in the general population, that is a non-Down syndrome population, it can really be characterized, that is developing drugs to treat Alzheimer's disease, as a history of failure. This is an article written in 2017, so only 5 or 6 years ago, and saying, why do so many clinical trials of therapies of Alzheimer's disease fail? And I think it's even mistitled, Why Do They All Fail? There was really no progress being made. And in this article highlighting different areas, we don't fully understand the biology of Alzheimer's disease. Well, we do. We have a pretty good understanding now with the accumulation of these pathological features. There's some exact mechanisms of what's going on, what's causing the damage that we're still studying extensively. The second item, the wrong treatment target. The therapies have gone off. They're all different components, really without showing any success, and other issues too. When do you start these treatment trials? Are we waiting too long to give a drug, maybe trying to resurrect cells or tissue that is already beyond repair? And then other components too. So the area of drug development that is now starting to show success is at this amyloid. Okay, so we talked about tau tangles, but I'm going to focus on just anti-amyloid type of therapies. And if we take a closer look at that cartoon figure that I presented earlier and look at the pathway. So I mentioned the enzymes that clip off the protein from the cell surface. There are drugs that can be given to inhibit the action of those proteins. So let's slow those down so we aren't releasing as much of these beta protein peptides into the extracellular space. Those showed not to be effective over the last several decades. And then you see, as we go further down and start to focus on the aggregation of this amyloid protein into ultimately the plaques, there's different steps of formation. And now through the advancement of drug therapies, there's a development of these monoclonal antibodies, and they're used extensively in therapies, a lot in cancer treatments. Anytime you see a drug commercial and the name of the drug is given with an ending of MAB, that stands for monoclonal antibody, and they're used in this sense to attack the plaques, either attack, I should say, the beta amyloid, keep it from aggregating, or actually go after the plaque and remove it from the brain. And there's this series, I have 5 of them listed here, and we'll take a closer look at several of them. So 2 years ago was kind of a hallmark release of a study result. That is a drug called aducanumab. One of them I showed in there for keeping the amyloid from aggregating, showed some success in reducing cognitive decline. Kind of a busy slide here, but if you look at the very first graph I have on that top row, you can see the multiple lines. The vertical axis shows a decrease in cognitive function. So the higher you go, the worsening. And that top line would be the group that received the placebo drug. And the purple one below that is the group that received the aducanumab. And there's space between them. And that's what we always look for if something is statistically significant. Is there a clear separation? And it is there. And if you look at the graph right below that, that shows the amount of amyloid reduction that we've seen. And using those imaging methods, we saw that there was a 70% reduction in amyloid. So this drug can clear it out, but the cognitive decline was 22%. Now, if you go to the other column, I show a different study called ENGAGE. They didn't see it there. So there was a lot of controversy with this study. There's always controversy in these scientific results. And these were among the experts in the field that were discussing how to interpret this. Nevertheless, it was very encouraging. It received accelerated approval from the FDA. So now if we go back to more recently, even the beginning of this year, at the end of 2022, there were more results. And this was another anti-amyloid therapy, lecanemab, in early Alzheimer's disease. And again, this is in the non-Down syndrome population that these studies were done. And the first graph, you can see now this shows cognitive function, but the way they presented it, they swapped it. So now as you go down, that's a decrease in cognitive function. And this would be somebody started the treatment when they were experiencing cognitive decline. The earliest stage is called mild cognitive impairment, early Alzheimer's disease. And when they took the drug, this lecanemab, they still declined, but not as much as the placebo group. And again, there is clear separation in there. And it turned out to be a 27% reduction in the rate of cognitive decline. And the graph on the second column then shows a comparison of that amyloid measure. The placebo group showed no reduction, as you would expect, even a little bit of increase, as you'd expect. And the treated group went down by 77%. So these drugs are clearing out the amyloid. Now, when this came out too, I think there was a lot of popular press about it. And I would say from clinicians, you heard disappointment. Well, 27% in reduction. I mean, yeah, that's something, but that's not going to get us where we need to be. I have patients, they need help. So I think there was somewhat lackluster enthusiasm. From my perspective, being a researcher, and I found it absolutely exciting. Before, nothing was showing improvement. Now we have something here. There is a clear effect. We're engaging a target that we're going after, the amyloid, and it is showing a difference. Now, it's not perfect, but this is how things always start out. You have to now continue to adjust doses, maybe add on other treatments to go after other targets. It's incredibly exciting, and I think it can only improve from here as more and more trials continue on. So this was just given at a recent talk earlier this year by one of our colleagues in the ABCDS study. Mike Raffi provided this slide saying the progress that we're seeing. Again, the field is just thrilled with these results. Aducanumab was given an accelerated approval. Lecanemab is now being reviewed by the FDA. It's anticipated this summer that it will be given a full approval. What he wanted to highlight, though, is none of these clinical trials enrolled any individuals with Down syndrome. And worse yet, as a publication came out on aducanumab appropriate use recommendations, one of the statements in their expert panel recommends against treating amyloid positive patients with Down syndrome as well as other dementias. Now, how incredibly frustrating. This was done for the sake of safety reasons, which I'll talk about a little bit more, but this didn't go unnoticed by the Down syndrome community. And I think probably a lot of you have seen this on the internet. We've had a couple of the families, I was aware of it, but forwarded it of our participating families onto me and said, you know, what do you think of this? Alzheimer's meds are here, but for Down syndrome community, it's still the 1980s. And with this Aduhelm, I have circled there, that's the marketing name now for aducanumab. There was a letter writing campaign by the Down syndrome community, and I suspect with our crowd here as well as our audience online that some people did actually participate in this letter writing campaign saying, we want inclusion in these research, we want access to the drugs, but at least give us safety data on it so we know how to use these drugs in Down syndrome. So as researchers in the field, we know that people with Down syndrome are just ideal candidates for these anti-amyloid trials. As Dr. Hartley was saying, it's prevalent in almost all cases. The genetic form of AD almost has full penetrance, and the Alzheimer's disease and Down syndrome is really kind of the same as we see in sporadic general population. That is the accumulation of these proteins. Now, albeit it's a lot earlier, but it's still, we're seeing the same neuropathological changes. So as we now consider going into having people with Down syndrome in these trials, using these therapies, the number one concern is safety. So I think the caution in that recommendation against it is warranted with safety. Down syndrome brain is developed under a different environment. We know there's more amyloid precursor protein. So what are the effects of these drugs going to be? You really have to take a careful look at these and have information before you would ever recommend having someone with Down syndrome take them. So this goes back to the lecanemab, same publication that I showed before, again, the non-Down syndrome population. And if you look at the adverse events, that is, they conduct these clinical trials, very carefully monitor anything that could be going wrong and record that and track it and report it. If you go down there, you'll see, for example, death, which of course is the most serious adverse event. The treatment group had 6 people that died as a result of participating in the study. But now shift over a column and look at the placebo group. And this is why you always need placebo groups for clinical trials. You're taking a group of people of a certain demographic, a certain stage in life, and who is going to die during that period from causes unrelated to drug. And you can see they're pretty well matched. So we can't necessarily attribute causation to taking the drug. And that's always very important, that we know how a matching group behaves in these types of trials. But if we go a little bit lower, these are real things here. I showed the acronym ARIA, and ARIA stands for amyloid related imaging abnormalities. These are changes in the brain that are only evident from imaging. People come in and get an MRI scan and they see changes in the brain of people that have been taking it. And if you compare the treatment group with the placebo group, now there's definitely elevated, up to 8 or 9 higher levels of this ARIA, ARIA-E. And I'll show a comparison. And this is, so ARIA-E, these are measured with taking a brain scan. E stands for edema. That would be a buildup of fluid. As you can imagine, there's these plaques in the brain that are deteriorating, getting carried away, and there might be some kind of response where swelling and a buildup of fluid in the area. And then the H stands for hemorrhage. That is, they show up as little microbleeds on an MRI. So potential, obviously effects that you wouldn't want to let go unchecked. The thing is, 84% of these RAE cases were asymptomatic. People didn't know they had them. They were imaging only. And the field is learning that these can be managed. In general, if you stop someone on this. If somebody's in a treatment trial, you start to see these, you can stop them. They usually resolve themselves. Now, that's not to say there aren't rare, very serious events that go with these, but that is, that's part of the drug testing process. But again, learning so much from these trials of how to properly manage it. So they are going to be present without a doubt in these types of trials. And so I showed two of them, the aducanumab, lecanemab, and then there's donanemab, which is another anti-amyloid that's being studied too. So it's not to say nothing is being done in the space of Down syndrome. There are actually vaccines being developed too. Vaccines kind of activate the immune response of your own body to attack plaques. That's another strategy that's been taken to remove the amyloid. And here is a vaccine that was tested in the Down syndrome population, looking at a safety profile, demonstrated that these are safe strategies. So I think we'll see trials using vaccines in the future too. What we're most excited about is the participation, the interest of the National Institutes of Health in this area. Now, the ACTC network is called the Alzheimer's Clinical Trial Consortium, was established by the National Institutes of Health to provide infrastructure for conducting clinical trials for the treatment of Alzheimer's disease. Okay. This is for the general population. What's exciting is within the last several years, they've committed one arm of ACTC-DS Down syndrome that is going to be specific, providing infrastructure to conduct clinical trials of treatment in the Down syndrome population. And Mike Raffi at USC is the head of that. He's part of our team. We're working with him. And his study is called TRACK-DS, and our ABCDS study participates with TRACK-DS, where when our participants come in, we said, would you be willing to be in a trial ready cohort? It's not committing to any treatment trial at this time. It's just saying you're willing to hear more about it. So as more information comes, they're building a group studying the prevalence of amyloid, the age of people. And once these trials are initiated, they'll have a group of people assembled that they can then talk to and say, would you be willing to participate? Here are the risks associated with this drug. Here's what you need to know about it. And you decide whether you want to be in this trial. Potentially, these are blinded, randomized trials. You could receive the placebo group, you could receive a treatment. But again, this is an area I'm very proud of here. It's the Weissman Center, where our site is the top recruiting, enrolling people for the TRACK-DS component. And we're hoping within a year that will be moving along, potentially with trials going. So with that, I'll end there. I just want to acknowledge that I understand the frustration faced by the Down syndrome community. We hear it from our participant families saying, why aren't things moving along faster? As researchers, it's frustrating for us too. But I don't want to end on a message of anger. I want to do it on one of encouragement. This is exciting stuff. I think that things are moving ahead now. It's a promising time. We couldn't do any of this without our families' willingness to come in, share their time with us, and give themselves to help us understand this and advance the research. So with that, I'll stop. I